Moving on to some important infections of airways and lungs from which we do get some questions. So we need to know a little bit about common cold in children, acute pharyngitis, acute epiglottitis, acute laryngotracheobronchitis or croup, acute bronchiolitis and pneumonia. So common cold, common cold that children often suffer from is a viral illness usually. And the most common causative agent, the only important question that comes from it is what is the most common cause of acute coryza or common cold in children? So what is the answer? It is rhinovirus. Okay. So most common cause of acute coryza or common cold in children is rhinovirus. Very, very important. Moving on to acute pharyngitis in children. Acute pharyngitis in children. The most common cause of acute pharyngitis in children. So most common cause in children. If we look at a bacterial cause, it is Streptococcus pyogenes. While if we look at a viral cause, the most common cause is adenovirus. Okay. Now, because pharyngitis can be caused by both bacteria and viruses, we need to know in which situation should we suspect bacterial or streptococcal pharyngitis. Okay. So, when to suspect streptococcal pharyngitis, because it has important treatment implications, as we will see. So, when to suspect streptococcal pharyngitis? So, we suspect it in a situation where there is acute onset pharyngitis with high grade fever. Acute onset pharyngitis with high grade fever. There can be tonsillar exudates, palatal petechiae. So, tonsillar exudates, palatal petechiae, and tender cervical lymphadenopathy. Tender cervical lymphadenopathy. The diagnosis can be done by taking a throat swab. We can either do a rapid antigen detection test or culture. Okay. So, diagnosis can be confirmed by a throat swab. Rapid antigen detection test. Or culture. Okay. And what is the treatment of choice for streptococcal pharyngitis? It is penicillin or amoxicillin for 10 days. Okay. Now, there are some important complications of streptococcal pharyngitis. Let us see what are they. So, complications of streptococcal pharyngitis are, so one is local complications like peritonsillar abscess. And there can be other immune mediated complications like acute rheumatic fever, acute post-streptococcal glomerulonephritis. So, acute rheumatic fever and acute post-streptococcal glomerulonephritis. Okay. Now there comes a question that in case of acute streptococcal pharyngitis, administration of antibiotics would prevent all the following except. So we need to know out of these complications which can be prevented by antibiotic, which cannot be prevented by antibiotic. So prevention by antibiotics. Can peritonsillar abscess be prevented by antibiotics? Yes. Can acute rheumatic fever be prevented by administration of antibiotics for sore throat? Yes. Can acute post-streptococcal glomerulonephritis be prevented? No. So treatment with antibiotics does not prevent acute post-streptococcal glomerulonephritis. But these antibiotics prevent the transmission. So antibiotics also prevent the transmissibility of this infection to others. Okay. So antibiotics also prevent transmission of infection to others. Okay, but they do not prevent acute post-streptococcal pharyngitis. Okay, right, that is a very important question. Another important MCQ is that antibiotics given within how many days of onset of streptococcal pharyngitis protects against rheumatic fever. So antibiotics given how many days within the onset of streptococcal pharyngitis prevents rheumatic fever, and the answer is 9 days. So ideally it should be started as early as possible, but it can be effective even if started within 9 days of onset of illness. So antibiotics given how many days within the onset of illness of streptococcal pharyngitis prevents rheumatic fever. The answer is 9 days. Okay. So that is about acute streptococcal or acute pharyngitis. Moving on to acute epiglottitis. So acute epiglottitis, the name itself is telling you it is an infection and inflammation of the epiglottis, acute in onset. One very important yet controversial question is, what is the most common organism responsible for acute epiglottitis in children? So previously the answer to this was H. influenza type B. Okay, so remember previously the answer was H. influenza type B. But now, currently in vaccinated children, so hip vaccination is now being going on for quite some time in the Indian National Immunization Schedule also. So now in vaccinated children, the most common organism is Streptococcus. So in vaccinated children, currently, the common organisms include Streptococcus pyogenes, Streptococcus pneumoniae, and Staph aureus. However, in unvaccinated children, now also H. influenzae remains a common organism. Okay, so in unvaccinated children. Now, how will these children with acute epiglottitis present? So, they usually present with acute onset high grade fever, with drooling of saliva, sore throat, acute onset high grade fever, throat pain, Drooling of saliva. So the child is so sick that the child cannot even swallow his own saliva. So there is drooling of saliva. Respiratory distress, muffled voice, stridor can be there. Okay. The treatment includes good supportive care, respiratory support, and use of third generation cephalosporins IV for 7 to 10 days, like ceftriaxone. So, supportive care plus IV third generation cephalosporin for 7 to 10 days, like ceftriaxone. So that is about acute epiglottitis. Now, in acute epiglottitis, one more thing that I would like to mention is in the diagnosis, you get something known as cherry red epiglottis. On laryngoscopy, we can see cherry red epiglottis. So I'll show you a picture of this in the images section, but what do you understand by cherry red epiglottis? So, the epiglottis is very red in color, congested and edematous. So, that is why it appears like a cherry. So, swollen red epiglottis is called cherry red epiglottis, which is seen in acute epiglottitis on laryngoscopy. Okay. And on lateral x-ray neck, you can get thumb sign due to swollen epiglottis. So, thumb sign on lateral x-ray neck. Okay, so cherry red epiglottis on laryngoscopy and thumb sign on lateral x-ray neck. So that is about acute epiglottitis. Moving on to a little bit about acute laryngotracheobronchitis, LTB or group. Acute laryngotracheobronchitis, LTB or croup. So acute laryngotracheobronchitis or croup. The most common cause of acute laryngotracheobronchitis or croup is parainfluenza virus. Parainfluenza virus. Okay. Clinically, it will start with a viral prodrome. Okay, so the clinical feature starts with a viral prodrome and progresses to stridor, respiratory distress. So starts with a viral prodrome and progresses to stridor, barking cough. Progresses to stridor, barking cough and respiratory distress. Okay. It usually has a less acute onset and it is usually less severe than acute epiglottitis. Okay. It has lesser acute onset and less severe course than acute epiglottitis. Okay. The treatment includes a good supportive care. So the diagnosis of acute laryngotracheobronchitis rests on this clinical picture. So it starts with a viral prodrome and then the child presents with a stridor and a barking cough and respiratory distress may be there. On chest x-ray, we get something known as steeple sign due to narrowing of airway. So again, I'll show you a picture in the images section. We get a steeple sign on chest x-ray due to the narrowing of the upper airway. Okay. Treatment: supportive care including oxygen if hypoxia is there. Supportive care including oxygen. Single dose of dexamethasone, oral or intramuscularly, has been found to be very effective even in mild cases of croup. So, single dose dexamethasone, oral or IM, effective even in mild cases. Effective even in mild cases. And it reduces the need for and duration of hospitalization. Reduces the need and duration of hospitalization. While in moderate to severe cases, so in moderate to severe cases, what do you mean by moderate to severe cases? Where stridor is present even at rest, hypoxia is there, severe respiratory distress is there. In those cases, supportive care, single dose dexamethasone plus nebulized epinephrine is also used. Now, in acute epiglottitis, the antibiotic of choice was IV third generation cephalosporin. Which antibiotic is effective in croup? The answer is none. Antibiotics are not indicated in the treatment of croup because croup is a viral illness, unlike acute epiglottitis, which was bacterial illness. So, antibiotics are not indicated. Because it is a viral illness. So, no role of antibiotics in the treatment of croup. Moving on to another important respiratory infection in children, that is acute bronchiolitis. The most common age group involved with acute bronchiolitis is 6 months to 2 years of age. Most common age group involved is 6 months to 2 years. The most common agent responsible for acute bronchiolitis is respiratory syncytial virus. So, most common agent or etiology is RSV or respiratory syncytial virus. Other etiological agents include parainfluenza virus, influenza virus, adenovirus, influenza, parainfluenza, adenovirus. Okay. Clinical picture, it will also present with a viral prodrome, low grade fever, cough, coryza followed by respiratory distress. Okay. So clinically it will present with a viral prodrome wherein there can be low grade fever, okay, coryza, followed by tachypnea, retractions and hypoxemia. Tachypnea, retractions and hypoxemia. On examination, we can get hyperinflated chest. Okay, hyperinflated chest can be there and wheeze can be audible. Okay, so on examination, hyperinflated chest. So we can get increased anteroposterior diameter of the chest. Okay, so hyperinflated chest and audible wheeze and crepitations. The treatment is mostly supportive, including moist oxygen inhalation, IV fluids, Specific treatment is available in the form of nebulized ribavirin, but that is indicated only in immunocompromised children and infants on ventilator. So specific treatment is available in the form of nebulized ribavirin, important for your MCQs, but usually not used in practice, and it is indicated only in immunocompromised children and infants on ventilator. Okay, so prevention of this acute bronchiolitis can also be done by a drug which is again important for your MCQs, that is palivizumab. So for the prevention we can use a drug that is palivizumab, again in immunocompromised situation, high risk situations. So important for MCQ purpose. So that is about acute bronchiolitis in children. Moving on to pneumonia. So pneumonia or acute lower respiratory tract infection in children. You know, pneumonia is the leading infectious cause of death in under 5 children worldwide. It is the leading infectious cause of death in children worldwide. Okay. Some important one-liners on pneumonia. The most common cause of bacterial pneumonia in children. Most common cause of bacterial pneumonia in children is Streptococcus pneumoniae. Okay. Most common cause of viral pneumonia in children is respiratory syncytial virus, RSV. Most common cause of pneumonia in neonates worldwide. Is group B Streptococcus followed by E. coli. While most common cause of pneumonia in children with HIV is pneumocystis jirovecii. So most common cause of pneumonia in infants with HIV is pneumocystis jirovecii. Pneumocystis jirovecii. Now the clinical features, the assessment and the treatment of children with pneumonia we'll be discussing along with the IMNCI guidelines. Let us discuss the approach to a child with cough or difficulty in breathing as per the IMNCI guidelines. So we will be discussing the latest recommendations as per the IMNCI guidelines provided by the WHO and adapted by the Government of India. So IMNCI refers to integrated management of neonatal and childhood illnesses. Okay, so we'll be discussing about the recommendation as per the latest IMNCI guidelines. So there is some change as compared to the previous guidelines. So let us see. So if a child comes with cough or difficulty in breathing or both of them, how do you assess that child? So The assessment of the child is done in the form of, so first you have to count his respiratory rate and you have to see whether there is fast breathing or not. Okay. So you count breath in 1 minute and see whether there is fast breathing is there or not. Okay. Look for chest indrawing. Look for chest indrawing. Look and listen for stridor and wheeze. Okay. Look and listen for stridor and wheeze. And look for danger signs. Okay, danger signs. Any danger signs are there or not. So these are the things that you will do if you are getting a case scenario or a condition where a child is presenting with cough or difficulty in breathing. Now, why we are counting the breath in 1 minute? Because we need to know whether fast breathing is there or not. So there comes the definition of fast breathing, very, very important, comes as direct question also. When do you call it fast breathing? Okay. So, we call it fast breathing. So, fast breathing is defined. So, the criteria is based on the age. Okay. In a child who is less than 2 months old, fast breathing is defined as a respiratory rate of greater than equal to 60 per minute. Okay. In a child 2 to 12 months old, fast breathing is defined as respiratory rate greater than equal to 50 per minute, and in a child more than 1 year age, so 1 to 5 years of age, fast breathing is defined as respiratory rate greater than equal to 40 per minute. So we have to see whether fast breathing is there or not, and we have to, very important, see whether any general danger signs are there or not. So what do you mean by general danger signs? So general danger signs include persistent vomiting, unconsciousness, okay, convulsions or seizures, inability to drink or breastfeed, lethargy. Some sources mention severe malnutrition as a general danger sign, some don't. Okay, it is a bit controversial. So, inability to drink or breastfeed, and we said lethargy. Okay. Now, this look for wheeze is a new entry in the latest guidelines. Now, in the current guidelines, it is now recommended that if wheezing is present along with either fast breathing or chest indrawing, you have to give a trial of inhaled bronchodilators, okay, rapid acting inhaled bronchodilators. So, the current guideline mentions that if wheezing is there along with either fast breathing or chest indrawing, along with fast breathing or chest indrawing, give a trial of rapid acting bronchodilators like salbutamol inhaled. Okay, give a trial of rapid acting inhaled bronchodilator up to 3 times. (15 to 20 minutes apart). Then reassess for fast breathing and chest indrawing. Okay. So, this use of inhaled bronchodilator is a new entry in the latest IMNCI guidelines, which was not there. Okay, give a trial of this rapid acting inhaled bronchodilator was not there in the previous guidelines. So, to summarize the latest guidelines, let us see. So, what is there in the latest guidelines is, so you have to look for some signs, you have to classify and you have to treat. Okay. So, signs, classification and treatment. Signs, classification So classify as and treatment. So if any general danger sign is there or a stridor in a calm child, so any general danger sign, okay, or stridor in a calm child, you classify it as severe pneumonia or very severe disease. Okay, and the treatment is you give first dose of injectable antibiotics and refer. So give first dose of injection ampicillin and gentamicin and refer urgently to hospital. Okay, so that is the most severe category, right? So if either chest indrawing or fast breathing is there, you have either chest indrawing or fast breathing. Okay, there is either chest indrawing or fast breathing. You classify it as pneumonia. And how do you treat? So one is give antibiotic. So usual first line recommended is amoxicillin. So give amoxicillin. So we are talking about oral antibiotic here, okay? Give oral amoxicillin for 5 days. Right? What else? So give oral amoxicillin for 5 days. If wheezing is there, give a trial of inhaled bronchodilators. So if wheezing is there, prescribe inhaled bronchodilators. So if wheezing, give inhaled bronchodilator for 5 days. Soothe the throat and relieve the cough with a suitable home-based remedy. So soothe the throat and relieve cough with a safe remedy. If coughing more than 14 days or recurrent episodes of cough, refer for evaluation for TB or bronchial asthma. So if cough for more than 14 days or recurrent wheeze, refer for evaluation of TB or bronchial asthma. Advise the mother when to return immediately. So you have to tell her the danger signs, okay? Like if the child is having very severe respiratory distress, not feeding anything, okay? Becoming unconscious, lethargic and all that. So advise when to return immediately. Advise the mother when to return immediately, okay? When to return immediately. And follow up in 2 days. Follow up in 2 days. One more thing that has been added here is if the oxygen saturation is less than 90%. So now use of pulse oximeter if available is also recommended as per IMNCI guidelines. So if the oxygen saturation is less than 90%, then also refer urgently. So in this category also, if the oxygen saturation is less than 90%, refer urgently. That is now included in the latest guidelines. Okay. Now, if the child has got no signs of pneumonia or very severe disease, then what do you do? So if the child has got no signs of pneumonia or very severe disease, okay. So if the child has got no signs of pneumonia, that means no chest indrawing, no fast breathing, no general danger signs, no stridor. So no signs of pneumonia or very severe disease. That means the child has no pneumonia. Okay. Cough or cold only. The child has got no pneumonia, only cough or cold. So how do you treat him? So for him we have to repeat, you have to do steps 2. If wheezing is there, inhaled steroids to the throat. If cough more than 14 days, refer for evaluation for TB or asthma if recurrent wheezing, and advise mother when to return immediately. So steps 2 to 5. So same steps 2 to 5 as we saw above, plus you advise the mother to return for follow-up in 5 days. Okay, plus follow-up in 5 days. So that is what you advise in the treatment of this acute respiratory infection in children now as per the latest IMNCI guidelines. So you can see that as per the latest IMNCI guidelines, what are the new changes? So one is, one very important change is if wheezing is there, then use of inhaled bronchodilators is now recommended. What else? If cough is for more than 14 days or recurrent, then you have to refer for evaluation for TB or bronchial asthma. That is also a new entry in the latest guidelines. And if oxygen saturation is less than 90%, then refer urgently. So these 3 things have been added in the latest IMNCI guidelines. Okay. So the guidelines, there is a color coding in the IMNCI guidelines. So how is the color coding? So anything which is written in a pink background, that means the child needs to be referred urgently. Okay. So any general danger signs or stridor in a calm child, that means the child needs to be referred urgently. Okay, referred urgently to the hospital. If the child has got chest indrawing or fast breathing, then that means if pneumonia is there, then you need to give specific medical treatment. Okay, and you need to refer if the oxygen saturation is less than 90%. Otherwise, you can just treat the child on ambulatory basis. Okay. And the green, anything written in the green background means the child is fine, does not need any specific treatment. So if there are no signs of pneumonia or very severe disease, no pneumonia, cough and cold, then just follow steps 2 to 5 and follow up in 5 days. So steps 2 to 5 means if wheezing is the inhaled bronchodilator, soothe the throat and relieve the cough. If cough is more than 14 days or recurrent, then refer for evaluation and advise mother when to return immediately. So the important things to note is, so there are 3 categories. So one is severe pneumonia or very severe disease, another is pneumonia, and the third category is no pneumonia, cough or cold. And the new entry in the latest guidelines are if wheezing is there, use of inhaled bronchodilator. If more than 14 days cough or recurrent wheezing, refer for evaluation. And if oxygen saturation less than 90%, even in the category of pneumonia, you need to refer urgently. So use of pulse oximeter if available is recommended as per the latest IMNCI guidelines.